I'd like to welcome you to this session, and we're going to be discussing laboratory testing for onychomycosis, specifically when is laboratory testing indicated, when is it required, when does it seem to be appropriate in daily podiatry practice. We know that onychomycosis is a common problem. It's found in up to 15% of the overall population in the United States. However, if we look at patients who present to our office and say, "Doctor, is this in fact onychomycosis?" of patients not in the general population, but patients who actually present for examination and treatment, onychomycosis represents well over 50% of the pathology that we see. Estimates range from 65 to 95%. Or rather 90% of patients who actually present to our offices. We know that as we have an increasing aging population, with aging we have increasing incidence of onychomycosis, and here again we are seeing this with significantly increased frequency in average daily practice. The most common infecting organism is T. rubrum, other dermatophytes in addition, but certainly most studies overwhelmingly demonstrate that T. rubrum is the most common infecting organism. There seem to be 4 standard situations in which we want to consider laboratory testing. The standard first argument is that we do know there are other conditions that can present that may mimic onychomycosis, and we certainly don't want to spend the patient's time and money and more importantly, not treat patients who require treatment if in fact the pathology with which they're presenting is not onychomycosis. So laboratory testing would be considered a part of the necessary differential diagnosis to say yes or no, is this onychomycosis, or is it onychomycosis with other comorbid conditions? For example, we might have a patient that has a hallux limitus, has a hyperextension deformity of the hallux interphalangeal joint with repetitive trauma to the nail, and then a secondary onychomycosis. Secondly, many of the newer therapies that are strongly advocated in our profession, the topical therapies in particular, are very expensive and can cost thousands and thousands of dollars. And these topical therapies that are advocated, which are quite expensive, have limited effectiveness in terms of we know that they only work for certain species of organisms, primarily dermatophytes. Therefore, if we're going to be utilizing an expensive topical therapy, laboratory testing would seem to be important to assure not only that it is a fungus infection, but that the patient is going to be responsive to the expensive therapy that we are prescribing. Thirdly, we know even today, with advances in topical therapy, that the most effective means to treat onychomycosis remain oral agents, oral terbinafine, oral itraconazole, oral fluconazole, for example. But these agents can be associated with significant adverse sequelae. And while the incidence of these problems are quite low, we nevertheless do have a patient that's going to be exposed to a small risk of side effects. Therefore, again, it would be nice to assure that we do in fact have a fungus infection and that the fungus that is present is likely to be responsive to the oral agent which we are prescribing. Finally, although T. rubrum and other dermatophytes overwhelmingly represent the most common infecting organisms, we do know that some patients do present with other infecting fungal organisms. It may be that the therapies that we are utilizing would not be effective against these organisms, such as saprophytic fungi, Candida species, and so forth. And here again, good arguments can be made for the need for laboratory testing under these circumstances. From a practical standpoint, there are 3 things that we want to know. Number 1 is it onychomycosis? And there are times when, if we're using non-specific therapies, for example, topical urea, or for example, laser therapy, these are therapies that are not species specific. We don't know that they are more or less effective against various specific organisms. And so we're going to initiate therapy such as laser. We really just need to know, yes or no, is it a fungal infection? Secondly, we need to know if there's a component of repetitive trauma, because if there's a component of repetitive trauma with superimposed onychomycosis, then in addition to our antifungal therapy, we're going to need to do something about that repetitive trauma. It may be shoe therapy, mechanical therapy, it may be surgical therapy to reduce the deformity present. But it would be good to know that, otherwise we will not affect a total cure. Lastly, we want to know if there is any additional pathology that also needs to be treated. For example, we may have psoriasis with psoriatic nail changes and superimposed onychomycosis. Generally, we have lists of these differential diagnoses. Some of them are common, some of these not so common, but we do know that there are other disorders that can manifest and present as in a manner similar to that of onychomycosis. Again, going back to just empirical thinking, we know that the majority of patients presenting to our offices with nail dystrophy, discoloration, hypertrophy, and so forth are likely to have onychomycosis just from a pure statistical standpoint. And we also know that statistically the majority are going to have T. rubrum. As far as testing is involved, there are 6 common tests that are utilized for onychomycosis. Direct microscopy, or KOH, is easily done in the office setting. It no longer requires heating with DMSO. However, the majority of podiatrists generally do not perform a direct microscopy in the office. DTM testing was quite popular for some years. Dermatophyte test media testing, unfortunately, now requires a laboratory certification burden, and most podiatrists, I think, have chosen to abandon DTM because of the standards that are required for the office in terms of laboratory standards. Culturing probably is the most common means by which podiatrists will attempt to verify the presence of a fungal infection and identify the infecting organisms. PAS testing and histopathologic examination has become very, very popular and is probably the most convenient means by which to evaluate nails for the presence of a fungus infection and the presence of other changes, particularly trauma-associated changes. The interpretation and reporting of PAS and histopathologic examination studies has become very sophisticated, and if one only requires identification as to yes or no there is a fungus, and yes or no there may be associated pathology, and speciation is not required, then PAS with histologic testing is probably the test of choice. Molecular genetic testing, without question, is the most sensitive test available for onychomycosis. It is not only the most sensitive, but the most specific in terms of identifying the infecting organisms. The issue that you have to consider with molecular genetic testing is the cost and whether or not that information is required by you. If you're going to be engaged in therapy that is species specific, if you're going to be using therapies such as oral therapies, if you're going to be using therapies that are expensive, under those circumstances where you need to know the species that's present, molecular genetic testing becomes the test that you must or ought to consider. It is more sensitive and more specific than is culturing. The downside of molecular genetic testing is, of course, the cost. Dermoscopy has also become increasingly popular in the evaluation of onychomycosis, as it has for many skin disorders. The advantage of dermoscopy, it is inexpensive, easily done in the office. The downside is that we have no identification of species. So if we look at the laboratory studies that are readily available, direct microscopy is easily done but provides no information regarding the viability of the organisms, nor does it provide any information regarding the species. PAS staining is the most sensitive test that we have short of molecular genetic testing. If it is negative, it is a very reliable indicator that there is not likely a fungal infection. It is also offers the advantage of showing trauma-associated changes and other changes in the nail. The downside of PAS is if you require speciation, it's not going to provide you that information. The problem with fungal cultures is that while they are readily available and less expensive than molecular genetic testing, is that there's a considerable false negative rate. And if you have a patient in whom you require speciation, again, if you're using an expensive therapy or a potentially toxic therapy, then you have to be prepared to deal with the consequences of a negative fungal culture. And you're either going to have to repeat that culture or go to a PAS. However, PAS and histologic testing, while more sensitive than culturing, will not provide you with the species information that you require. And again, if you're culturing, the presumption would be that you need to know the genus and species because your therapy will be dependent upon or determined based upon the genus or species present. Molecular genetic testing, the question you have to ask yourself is, do I need the information? But if I require information regarding genus and species, then certainly molecular testing is your most sensitive test. On the other hand, if I'm going to be using a non-specific therapy, for example, laser therapy, or some topical that is not species specific, then I don't require the information from this test, and therefore the cost is really not justified. KOHs have changed a lot over the years. Again, with DMSO now, it does not require heating. There are counterstains that are available to accentuate the fungi. The problem with KOH, again, is it gives you no information regarding species, and it doesn't tell you about the viability of the organisms. PAS testing with histology has become increasingly popular. It is a very sensitive test. It is much more sensitive than our standard cultures and much more sensitive than KOH. So it is a very reliable test for determining, do I or do I not have a fungus infection. So if one merely needs to verify fungus infection and speciation is not required, then PAS and histologic testing is the way you probably want to go. When you do PAS testing, you're basically staining polysaccharides that are in the fungal cell wall. If you add histologic examination, you could obtain wonderful information regarding the presence of trauma, the presence of findings that are consistent with other pathologic conditions. And PAS testing is less operator dependent. Proper fungal culturing requires good technique, and not everyone follows particularly good technique in obtaining fungal cultures. Usually, I would say 90% of the time, PAS testing with histopathology is adequate for the needs in the office, and the turnover is rather rapid. It's a 3-day turnover, and gives us more than adequate information. It is an alternative to fungal culture, certainly alternative to KOH. The nail clipping is placed in a formalin-filled container. It is the most sensitive technique for diagnosis of onychomycosis other than molecular genetic testing. And again, the real advantage of PAS and histologic testing is has a very high sensitivity, much higher than cultures, much higher than KOH, not higher than molecular genetic testing. And it does help you to identify other causes of nail dystrophy. Again, the downside is if you require speciation, it's not going to provide you that information. Fungal cultures remain very, very popular. 2 fungal media are generally required, and it's recommended that no antifungal therapy be utilized for 2 weeks prior to obtaining the culture. I think one of the real downsides of fungal cultures is that proper collection technique is important. I think all too frequently a piece of the nail is just clipped and sent off to the laboratory, and we're really not getting representative samples in general for the fungi presenting. You want to collect the samples as proximally as you can get and get some fungal debris present. It requires up to 6 weeks to get back results, however, for genus and species. And again, if we don't obtain proper culturing specimens, and if we don't transport these specimens in a relatively expeditious manner, there's a high incidence of false negative results. You want to remember also there are many types of clinical onychomycosis. There's distal lateral subungual, there's dystrophic, there's superficial white, there's proximal white, and so forth. And some of these clinical types of onychomycosis require particular culturing mechanisms. So the differential diagnosis of onychomycosis, unfortunately, with culturing is difficult to obtain. Frequently, there's a low number of fungi. They may have decreased viability, and we lose them in transport. If you've been applying topicals or using orals, or the patient's had some prior therapy, this will affect in some patients the culture results, and we have the effects of bacteria. So unfortunately, false negative cultures are quite common. Genetic and molecular testing far and away represents the most sensitive and specific testing that we can do. It has excellent sensitivity, short turnaround time. It certainly will expedite the treatment of onychomycosis if there is some urgency to initiate therapy. The downside is the cost. And here again, the question you must ask yourself is, do I need this information? And if speciation is required, then certainly molecular genetic testing represents a test of choice. If, on the other hand, you only require confirmation that there is a fungus, then probably PAS is a more appropriate test in terms of cost effectiveness. We've seen recent enthusiasm for dermoscopy, and is illustrated in this patient. With dermoscopy, it is said that the proximal margin will present with this so-called aurora borealis effect. And again, dermoscopy rather represents a good screening test. It does not provide you any information regarding genus or species. But here again, we want to remember that 80 to 90% of the time, these infections are trichophyton rubrum. So looking at the common tests that are available to us, in terms of sensitivity, molecular testing is far and away the most sensitive. The next most sensitive would be biopsy with PAS. And you can see that cultures are actually the least sensitive means in terms of determining the presence or absence of a fungal infection. There are some practical considerations, and here's one I've selected for examination. That would be, for example, lasers. Laser treatment of onychomycosis has become rather popular with podiatrists and to some extent dermatologists. Well, we know that if we look at laser therapy, it does not cure onychomycosis, and it makes the nail appear better. And the actual mycologic and complete cure rates of lasers in terms of resolution of onychomycosis is low. Now, this is an issue in special need populations because we know that onychomycosis represents a potential source of repeated episodes of cellulitis. For example, we've had the Infectious Disease Society of America stating that tinea pedis and onychomycosis at times needs to be addressed in patients that are having repeated episodes of cellulitis. For example, we've all seen those patients with chronic venous insufficiency or lymphedema, and they have the edematous legs, and they have onychomycosis, get repeated episodes of cellulitis, and there's been increasing calls for more aggressive treatment of the tinea pedis and onychomycosis. Immunosuppressed patients, patients who are on chemotherapy, for example. And importantly to the podiatrist in terms of incidence, patients with peripheral arterial disease and the diabetic patient. We've known since the classic work of Jeff Robbins that diabetic patients who have onychomycosis are at increased risk for infections and ulceration and even limb loss. So that we have certain populations where the treatment of onychomycosis is considered important and not trivial and needs to be done. And if we use something like laser, for example, or we use the wrong topical therapy and we dispense a product out of our office which may or may not work, what we're doing is depriving patients who require aggressive treatment of onychomycosis. We're denying them actual treatment. So that we do have patient populations where it is important in terms of risk reduction to aggressively treat the onychomycosis and recognize that improved appearance of the nail does not equal resolution of onychomycosis. In addition, we know that certain therapies like laser, to a lesser extent some of the more aggressive topical therapies, can result in an injury to soft tissues, and this could result in some occasional rather significant pathology in the diabetic patient, the patient who's immunocompromised, the patient with vascular disease. So here again, consideration should be given to at least verifying the presence of a fungus. Now, if we have a non-specific therapy, again, like topical urea or laser therapy, speciation is not required. We know that testing, therefore, is critical in these populations, and when we are using non-specific therapies, we just need to verify yes or no it is a fungus, and probably PAS is sufficient for those patients. This was an interesting recent paper that was published in JAMA Dermatology, and it's available to you to read online at no charge. I'm going to summarize this for you. The authors point out that if we look at the state of onychomycosis today, we still know that oral agents yield superior results to topical therapies, and this is unarguable. So oral terbinafine, oral fluconazole, oral itraconazole still result in superior cure rates to topical agents. However, and certainly in podiatry this is true, many patients have been scared off from oral agents. Their primaries say, well, don't let anybody give you these terrible drugs that will ruin your liver and your kidneys and so forth. And many clinicians are fearful of utilizing oral agents and tend to rely on topical agents. We also know that the oral agents now have become inexpensive. There was a time that terbinafine was several $100s a month. Now, at least here in the St. Louis area, $10 to $15 gets you the entire 90-day course of therapy. So from a practical standpoint, we have several options. One is we could look at these patients and say, well, I'm going to assume, based on statistics, that the patient has onychomycosis, and I'm going to treat them empirically for probably T. rubrum with topical or oral therapy. Or we can confirm the presence of an onychomycosis infection by in-office testing with either DTM or KOH. Or we can order a PAS study, or we could order a culture or genetic molecular testing. The American Academy of Dermatology does recommend confirmatory testing to reduce wasteful spending and reduce the incidence of adverse side effects, and this makes sense. Again, if we do pre-testing for patients on whom we're going to prescribe, say, terbinafine, and we eliminate patients that do not in fact have onychomycosis, then we reduce the number of patients at risk for side effects. And if we do testing to demonstrate that the patient on whom we're going to prescribe an expensive topical does not have onychomycosis, then we eliminate the use of $4,000 or $5,000 worth of topical therapy on a patient that does not in fact have onychomycosis. So this particular study made an assumption that 75% of patients presenting to our offices for evaluation do in fact have onychomycosis. And it said, look, the price of terbinafine now is extremely low. The topicals are extremely expensive. So they looked at several situations. What would be the cost of treating patients just empirically with terbinafine or empirically with efinaconazole with no laboratory testing? We're just going to presume it's T. rubrum or other susceptible dermatophyte, and we're going to presume it's onychomycosis. Or The cost of treatment with pre-treatment confirmatory KOH or PAS, if the KOH was negative, therefore eliminating from treatment patients who did not have evidence of onychomycosis. He looked at the cost of pre-treatment confirmatory PAS, just saying yes or no, it is a fungus. And they included in the study the cost of harm should a patient develop, for example, hepatocellular toxicity from terbinafine. And the results were interesting. If you looked at, for example, pre-treatment study with KOH or PAS before prescribing efinaconazole, this could save as much as $406 per toenail, again by eliminating patients who did not in fact have onychomycosis. And it would take $90 million plus of testing to prevent one case of clinically relevant hepatotoxicity from oral terbinafine. And the reality of this study shows the following. The incidence of hepatocellular toxicity from oral terbinafine has been greatly exaggerated. And the reality is the incidence is between 1 in 50,000 and 1 in 100,000. So the incidence of hepatocellular toxicity is extremely low. We know that oral terbinafine remains highly effective against dermatophytes, but we do want to eliminate the presence of non-sensitive saprophytic fungi, candida, and so forth. We do want to do testing in patients who may be considered higher risk for adverse sequelae, such as patients with a history of having alcohol abuse or a history of hepatitis, or patients that have been exposed to or are taking hepatotoxic drugs for other comorbid conditions. Because, and again, looking at the expense of these topicals. Going back to non-specific therapies again, such as laser, urea, and similar agents, we want to remember these are not species specific. So in those patients in whom you're using non-specific therapy, you're just going to, say, debride their nails and reduce pressure and bulk of those nails periodically, and you just want to verify that you are in fact treating a patient with onychomycosis, or in the patient that you're using non-specific therapy, simple confirmation is all that's required, and your most sensitive test again would be PAS with histologic study. So in those patients, the cost of advanced testing such as molecular genetic testing or even culturing is simply not supported. On the other hand, if you're using species-specific therapies, expensive therapies, potentially toxic therapies, then certainly speciation would be considered appropriate. Now, looking at this again in the general context of treating onychomycosis in our offices, this is position statement of the British Association of Dermatologists, and they looked again at therapies that are available, and terbinafine is still considered the first-line treatment for dermatophytes, absent the presence of contraindications to use the medication. Itraconazole is also considered first-line treatment for dermatophytes. Fluconazole is considered a reasonable alternative in patients unable to tolerate either terbinafine or itraconazole. Combination therapy with both orals and topicals recommended if the response to monotherapy is considered to be unlikely. For example, the patient with advanced dystrophic onychomycosis of multiple toenails. And griseofulvin is really no longer considered an appropriate choice due to the high reoccurrence rate and low efficacy. The American Academy of Dermatology and the American Board of Internal Medicine had developed a Choosing Wisely initiative for the treatment of onychomycosis, and they do recommend that in general one engage in some type of confirmatory testing before initiating therapy, and they had recommended in particular either PAS studies or fungal culture. And again, of the two, the PAS is the more sensitive, it lacks speciation. Fungal cultures better for speciation, certainly, but unfortunately less sensitive. In documenting treatment for onychomycosis, there are various staging systems available, and it is helpful to adopt some system or other. This was one recommended by Friedlanders and others, but there are certainly other techniques available for documentation. So the question then is, how much testing do I need? And this is the answer. Do you need to simply confirm yes or no it's onychomycosis? And if that's all the information you require, then your clinical examination together with KOH, PAS, and dermoscopy is going to be sufficient. If you require identification of genus and species, then culturing is certainly an option. However, it lacks sensitivity, high rate of false negatives, and so if you require speciation information, molecular genetic testing would be the way to go. If you require information as to just yes or no, is it a fungus, and yes or no, is it possible there is a mechanical component or a secondary comorbid condition, then here again KOH with PAS testing would represent the appropriate best choice in most circumstances. So hopefully this review will give you some additional thoughts on how to approach this issue of testing for onychomycosis in the average podiatry practice. Thank you.